Hi, everybody. It's Dr. Sporwart. Concept of elimination. We're focusing on the renal system next Tuesday. So I've done a voiceover PowerPoint for the concept of elimination. I can't promise that I'll have a voiceover every single week for the concept. It's going to really depend on the content and what we do in class. That's going to drive whether I do a voiceover. But for the sake of time today, this is about 18 slides. This is covering Module 5, Concept of Elimination, specific to the urinary system or the renal system. We start exemplars on the GI system next week, which will focus back on the concept of elimination for the bowel. So I'm just separating out the two for my sanity. All right, so this is the concept of elimination and reference and preparation for our exemplars next Tuesday on BPH and renal calculi. All right, our objectives, short and sweet: analyze the physiology of the urinary elimination in the body. All right, so what do we know about the kidneys? It basically is going to secrete and eliminate physiological waste products by the kidneys in the intestine. So when we eat, swallow food into our stomach, the food is broken down with bile and various types of acids to churn the food into chum, by which then you have the metabolism of the liver, you have more excretion of bile from the gallbladder. It's all of these mixtures going into one. Then the contents of the stomach and that process proceed into the small intestine, which is broken up into three areas of the duodenum, the jejunum, and the ileum. You need to know those pieces of it because that is where the increase of the nutrients takes place, and the body through the small intestine is giving and taking nutrients as to what we need: electrolytes, nutrients, what we need to keep on board for energy and fuel, what we can get rid of. What we're getting rid of is the solute or the liquid waste form that is then transferred into the kidneys. As well as excessive liquid is not needed for homeostasis. So when I say homeostasis, I'm talking about that yin and yang of what the body needs to get rid of, what the body needs to keep. All right, so this is the whole process. And when we talk kidneys in pharmacology, we really looked at the kidneys being your primary organ of elimination. So bring it all back up, it's elimination. So this is the physiological standpoint of everything going through the kidneys as the primary organ of elimination. Bowel elimination, the reason I left this in here is that you can see the difference between solute waste, which is liquid, kidney, and bowel elimination, which is the unused portion, solid, ingested. So just to separate it out, pretty straightforward. Urinary elimination. So the kidneys really have a huge amount of responsibility besides just elimination and separating out what we're going to keep in the body for energy and what we're going to make into liquid waste. Okay, so that is where it comes into that controlling the blood concentration and the composition. So as you know, the kidneys play a very important part with electrolyte balances, nutrient balances, your blood urea, your nitrogen, or your BUN, which is your lab value, and that's part of that composition and concentration, and that's where the blood urea and nitrogen really talk about that lab value. All right, and how the kidneys are doing in managing that homeostasis of the blood concentration, getting rid of the urea, getting rid of the nitrogen, and yet keeping the healthy part of what we eat so that we have the fuel and the energy. It also gets rid of excess fluids, right, and also manages the electrolytes. The two in particular are the sodium-potassium pump. All right, so know your sodium values, 135 to 145, potassium 3.5 to 5. You know, very small window for potassium. So the kidneys play a huge role in the sodium-potassium pump and those lab values, and critical, as we know when we talk about cardiac later in the semester as it relates to kidney function. All right. Because I'm talking physiology, and that means the function of, please know that I was busy this morning. Anatomy TV that I referenced in the library, I did put in module, whatever module I'm in, week 2, module 1, I have provided the PDF from the Anatomy TV from StatRefs to the library. Um, it's 1 page, 2 page, that's the anatomy. So when I'm sitting here talking kidneys, you need to go in there. If you need to pull it up alongside, look at it later, come back to this part of the video. But you need to know the anatomy for the glomerular filtration rate, which is what I'm talking about, which is responsible for controlling blood concentration, the composition of what's in our blood, and keeping excess fluids or getting rid of them, ridding excessive fluids, and then of course I just talked about the electrolyte piece. So caveat, come back to that. You need to make sure that you can articulate the function of the glomerular filtration system. Okay, normal urinary elimination is just the process of the concentration of our electrolytes, our ions. But we need to maintain this with having neurological and muscle function, bone strength, and cellular regeneration. Do I need you to know all that? No, I don't. But you need to understand the concept as it feeds into what we're going to do with BPH, for example, next week, and having kidney stones and how that's going to affect the functionality of the job of your 2 kidneys, which sit at the flank of your lower back, right? So the other huge thing that kidneys manage is our blood pressure. And we talked a little bit in pharmacology about what's called ACE inhibitors, which is a classification of medication. And then we talked about ARBs, and that's another medication classification. But those medications control blood pressure. And their mechanism of action is they control the blood pressure in the kidneys. So the kidneys have huge responsibilities, right? When we talk cardiac in our 3 weeks of cardiac function later in the semester, you have 3, 4 classifications of medications that directly impact blood pressure and heart rate, for example, but they work specifically at the cardiac muscle. So your kidneys are responsible for maintaining regulation, normal regulation of blood pressure to promote adequate circulation, the oxygens and the nutrients, okay? So urinary function, again, that anatomy, if you're a visual person, but pull it up and look at it because it breaks it down here on this slide and also in the Anatomy TV, the PDF that I posted. So you have your upper urinary tract, or your kidneys and your ureters. All right, so here's my 2 kidneys, literally, right? And then they come together, and the 2 ureters come to the bladder, and that becomes your lower urinary tract. Your bladder is nothing but a reservoir that holds urine. Your urine's acidic, okay? Its pH is less than 7. It's acidic. It's supposed to be. It's a waste, right? And then you have your urinary bladder, and then you have your urethra and your pelvic floor. For females, the urethra to urinate. As I tried to walk around yesterday during the skill splits, the female urethra is much shorter than the male urethra, so therefore the women are at higher risk for UTIs and the Foley catheter conversation in safe practice. And the pelvic floor is the floor that manages the muscles and keeping things like the bladder where they're supposed to be, especially for women. We'll talk again with the BPH with the bladder and the men next Tuesday. All right, so have a visual of the upper and the lower and the jobs of the kidneys and the ureters, your transport tubules, the urinary bladder houses, reservoirs, the urine. The urethra is the tube then causes the expulsion of water waste or pee or urine, however you want to terminology. There we go. Urination. 2 other words. Mictration, voiding means the same thing. We're urinating. Process of emptying the bladder, collects in the bladder. This is really I use the word fascinating. I try to make learning fun because I love it. So as a bladder fills with urine, okay, you have pressure sensors on the outside of the bladder that stimulate these receptors, and that transmits impulses through the reflex center of the spinal cord and goes up to the brain and says, hey, wow, you got to pee, you got to urinate. Okay, so that is part of that impulse. All right, so when I would talk about, say, spina bifida or patients who are quadriplegics or paraplegics, they don't have this neurological impulse because quadriplegics and paraplegics and patients with spina bifida have that disconnect due to the neurological um, condition. Okay, so here's the other thing. So time and place appropriate. So if when you go to void, urinate, and you're going to pee because it's the conscious part of the brain relaxing, so urination occurs, right? But if you are sorry, if you're in an inappropriate place, you're in a long car ride, and there is, an hour to the next rest stop, for example, your conscious part of your mind will actually delay the urination, even though those stretch receptors in your bladder, you may feel pressure in your lower abdomen area, or your, right at the pelvic area, at the at the lower part of your abdomen, but your conscious part saying you got to wait. You got to wait. So it'll subside. The feeling to pee, the voiding will subside, but you still got the pressure. You still got the feeling. That's not going to go away. And then the voluntary control, when you get to where you can, it's appropriate, then everything relaxes. But the whole piece of this part is the neurological component, and so that's going to feed back into those chronic health diseases, like spina bifida, a quadriplegic, a paraplegic, anywhere where there's a neurological disconnect for whatever the condition is. Patients do not know their bladder is full. They don't have the sensations. They don't know that they have to urinate. And these are the folks that have indwelling Foley catheters for their entire life. They have suprapubic indwelling Foley catheters because they don't have this reflexive ability that we do because we don't have these conditions. Patterns of voiding, it varies person to person. The older we get, and I'll talk about lifespan considerations shortly. We should at least void every 6 hours. We definitely have to stay hydrated. So this, the patterns of voiding just varies. Just be mindful that, when we talk about abnormalities of elimination, then patterns of voiding would be not within normal ranges for those patients. All right, let's see if I can get this to work. Cool. So here comes back to a little bit of the factors that could affect urinary elimination: fluid and food intake. So if you drink a lot of water, again, you're going to you're stimulating the kidneys to keep fluids and get rid of excess fluids. Food intake, definitely going to depend on the food intake, and there's specifically not one that's coming to mind. But from a fluid standpoint, increasing coffee is a stimulant, so that's going to generate your kidneys to work more. Gets all the juices flowing, if you will, in the morning, but it's excess fluids. Caffeine will eventually be voided out. If you drink a lot of coffee, you might actually smell caffeine in your urine. Okay, or coffee, excuse me, not caffeine. Muscle tone, especially in women. The uterus sits above the bladder, so the more pregnancies a female has puts more stress on the bladder and the pelvic floor, if you will, and pelvic floor's muscle, and so it starts to weaken and the bladder may droop, and that can cause urinary incontinence, coughing, sneezing, stress incontinence, urge incontinence. So that muscle tone plays a factor. More relevant to women, but when we talk BPH, you'll see where that muscle tone can come into play with the elderly male population, where BPH tends to be more predominant. Psychosocial factors, drug use, alcohol use, cigarette smoking. Blood pressure. You have constriction over time of smoking, causes increased blood pressure, and that's going to increase blood pressure management by kidneys. The older we get, kidneys get old. You can see a domino effect that doesn't have positive outcome. Pathological conditions, don't have any off the top of my head. at the very moment, but I will look that up. Surgical and diagnostic procedures. Um, what comes to mind, C-sections for women will affect the pelvic floor management. So yes, I definitely can have the stress incontinence, the urge incontinence, coughing, sneezing, dribbling, etc. Diagnostic procedures. Um, if it's a diagnostic procedure, so if it's doing a straight cath, for example, to check post-void residual, we would have a possibility where that can affect elimination. Um, it may take some time for the patient to actually void um, if they have a urinary catheter. And diagnostic procedures, if, for example, there is a dye required for a CAT scan or a cardiac catheterization, where we have to inject contrast dye, that can have an effect on the elimination side to ensure that the kidneys are diuresing the dye as the body needs to get rid of it because it's not a natural product the body wants to hold on to. Medications, huge. We have over-the-counter medications, antihistamines. They will dry you out. You have a sinus infection, you have allergies, you got a runny nose, your eyes are running, you're hacking up a lung. Antihistamines will dry you out. So what that's going to do is reduce volume just because of the medication, and that's going to reduce urinary output, or your kidneys aren't going to have a whole lot to make urine, so you're going to be more drier. We'll talk a little bit about those over-the-counter antihistamines. Nothing specific, but how it can be a complication to a male patient that has BPH. On the flip side, patients who are on diuretics, furosemide, HCTZ, any loop diuretics, regardless of how they use their loop diuretics, they work within the loops of the glomerular filtration system of the kidneys, so the patients are going to diurese more because they have hypervolemia or fluid overload, congestive heart failure, congestion fluid. So yeah, so that's all can be contingent on what that looks like based on some of these examples that I've tried to provide. All right, genetic considerations, physical, cognitive developmental disability. The best way I can say this is that there are lots of different examples. I talked about paraplegics, quadriplegics, spina bifida is on here as a genetic consideration because this happens in utero upon birth. It's not something that develops after birth. Cognitive delays could be anywhere from Alzheimer's, dementia, physical quads, as I mentioned, I'm sorry 1,000 times so far, paraplegics, developmental disabilities, autism, attention deficit disorders, can, not will, can, may have an impact on urinary elimination. I know that I hear very common in my practice, as well as teaching, that folks want a black and white answer. There isn't one. It's all based on assessment and individual considerations of how the patient and or the family is presenting. That determines the assessments, the interventions, the plan, and the reevaluation, and how that's going to look in the long run. Family history of incontinence. So when I talk next week, and I'll start it right now, modifiable versus non-modifiable risk factors. Non-modifiable can't do anything with. Genetics, I can't touch it. That's where family history of comes into play, fill in the blank. Modifiable, yeah, I can change my lifestyle. Choices, do I want to? Can I? Do I understand how to? And that in and of itself we'll talk about more. Every single week we're going to talk modifiable. Because when we talk objectives every week and you see teaching strategies, that's when non-modifiable is going to be part of that conversation. Genetic considerations in those non-modifiable. Age, I can't change age, right? Parkinson's, Alzheimer's, I mentioned Alzheimer's, I neglected Parkinson's, so I'm going to add multiple sclerosis to that. Parkinson's and MS is a chronic health condition. You will learn that in 211 with Ms. Noggle. Age-related changes in function as we get older. Here's your men with the enlarged prostate. We'll talk about BPH next week. I talked about women, weakened muscles supporting bladder or urethral sphincter, much more common. It's common as women age, but it's much more common with multiple childbirths. Okay, both have decreased bladder capability or capacity. So the muscles itself start to sag with age. The increased urgency upstairs to urinate with a normal neurological function that's intact. So therefore, your frequency of urination increases. Okay, it's just part of getting older. All right, and then if you're a young woman in your 30s, late 20s, childbirthing years, let's put it that way, you may notice that when you get into, you're not there yet, but in your 40s and your 50s, as we age, and you not compound it because childbirth is wonderful, but it already has weakened muscle walls in the pelvic floor. It just is what it is. Um, You'll talk about pediatric populations in your maternal health class in the summer with 113. So bring this back into play then. Your GFR rates for newborns are lower than adults because they're newborns. We talked about that in pharmacology. Remember, we talked about, and I have to pull my muscle memory, immaturity was the word I used in the first week or two of 117. Immature kidneys, immature liver, okay? So here with urinary system, limitations regarding concentration. So we have to monitor dehydration specifically in our newborns. Healthy newborns typically void within the first 24 hours of life. So it's important to ensure that they do. Not going to go a whole lot into that, but here's some foundation to pull forward for yourselves when you hit 113. So we're always assessing for fluid intake, bladder distension, restlessness, and pain. Once the first 24 hours has passed and the newborn has urinated for the first time, if I remember correctly from my newborn baby days, you change, I think, on average, anywhere from 10 to 12 diapers a day, which speaks to hydration, normal urinary patterns, etc. You'll get into more detail with that in the summer. Again, urination color of the newborn, I'll leave that to the experts. But to cover Module 5 concepts, maybe clouding the newborn and straw-colored in early infancy. We do want it, as you know, when we talk about urinalysis, that we like it like light straw color. Amber speaks to dehydration. Obviously, blood with clots is not a good thing. We'll talk about the TERPs with the BPH, which is the surgery for prostate removal. Then we have our toddlers and preschoolers. My biggest thing here is number 3 and 4, washing hands and flushing the toilet. And for females in particular, required instructions with wiping. We don't want to wipe back to front because it can introduce fecal waste that can ascend through the urethra in the bladder. And that's where the urinary tract infections come in. As we said already, it's more predominant in your female population. So be mindful of that when we're teaching, especially with preschoolers, get into Erickson's stages of development. You'll talk about that in 113. I don't know if it's still out there as relevant in education, but we really don't encourage young females, toddlers, to take bubble baths. I think that increases urinary tract. It's not a wise tale, but I can't speak to whether it's still evidence-based with teaching. So pick that back up with 113 in the lifespan. School-age children, then our kidneys start to more develop, increasing urination times to 6-8 times a day. School-age children to me is, I'm going to go with 7 and up. How's that? You may see nocturnal enuresis or bedwetting. It's prevalent in deep sleepers. It doesn't really become a problem until after the age of 7. I could speak to a little bit of that. It's going to be a psychosocial component, bedwetters over the age of 7. Some of the literature out there will speak to red flags ought to be going off in our nursing and in our healthcare system. It speaks usually to some forms of abuse, sexual, physical, or verbal. So that will, I'm sure, would get discussed in sensitive interventions and assessments in 113. Pregnant women, I've spoken to this, so but you will notice that as nurses, you don't notice. I'm not saying as I was going to say as if when you've been pregnant, you know that by your third trimester, the weight of the uterus and the enlargement pushes down on the bladder, and that increases frequency throughout the day. So we tend to, when we're pregnant, we tend to urinate more in the third trimester. Therefore, with more fluids waste from the fetus and mom, okay, that the glomerular filtration rate picks up in sense of the filtration of waste products. So that's just, you have your whole tubular reabsorption, that whole process happens. That um, probably spoken to in 113. Um, Pregnant women with the kidneys. So this is speaking directly to what's called gestational diabetes. So even if mom is not a diabetic, she may, quote unquote, have gestational diabetes that has to be managed during pregnancy. Typically resolves at some point after birth, and that some point is individual, and that does get discussed in NUR 113 in this summer. Postpartum, that I'm going to leave to your 113 folks. There's always a risk for UTIs in females, especially when we don't empty our bladder. And urinary output increases in early postpartum period. As we get older, I'm a geriatric nurse. You know, I try to pick up as much as I can with the peds and mom, just to making sure there's some discussion of lifespan considerations. But I'm really much more of a I hate the word expert, but I've practiced 20, 30 years geriatrics as an NP and in-home care. So as we get older, I'm 57, so I guess my renal function has begun to decline. Lovely. Blood flow to kidneys decreases. Atrophy means to decrease in size. So therefore, that the supply of blood flow also decreases. Urine becomes more dilute potentially. All this is just keeping this in the back of your brain, that as we get older, things get older. All right, our kidneys, in this case, for this conversation, get older. We might be wrapping it up here, I think. We're getting there. Very good. Yeah. Um, Kidneys excrete more fluid, electrolytes at night. We get up at night and pee a lot. And when we're peeing electrolytes, that's where we start talking electrolyte imbalances. So we have to be very careful, especially in the elderly. I know there's a conversation with 117 on the Beers criteria. At the end of 117, that is specific to medications that we do not prescribe to the elderly, or we're very cautious with because of the kidneys in elimination, and things start to slow down. So the retention of medications, increase of drug overdose because we're not filtering well, we're not excreting all of it, increases adverse effects, etc. So we have to be very mindful of that, especially when we're doing those medication reconciliations with the population of folks over the age of, we'll just go with 45. The older we get, things just continue to go downhill. I'm sorry. We really have to, all kidding aside, really look at increased risk of hyponatremia, which is a sodium level typically less than 120, 135. We get into cardiac issues as well with potassium levels, especially if they're on medications that do not keep potassium, which is your potassium-sparing diuretics and your non-sparing. Lasix pees out potassium. So we have to always look at our potassium levels in our blood work. Prescription diuretics, hypertension, cardiac conditions. I'll bring all this back when we do cardiac.